Welcome back, guys. This is episode 4 of The Unscrubbed. I'm Jake.
I'm Joe.
What's going on, mate?
Not much, mate.
Yeah.
It's been too long.
It has been a little while since the last episode. I do notice these are the chairs that we first started our podcast on.
Yes.
And for the viewers that are our fanatical viewers, I would say, you were sitting bolt upright and didn't move the entire time.
Yeah. So I before that first podcast, I was probably I reckon it was a week to 2 weeks post having a discectomy on my spine.
Yeah. Yeah.
So
run us through it. So you injured the back, lifting up the biggles.
Yep. My kid's heavy and reached over awkwardly and felt a big old bang while I was in Japan. And so then basically had a horrendous nerve pain for 6 weeks.
Yeah.
Then
Foot drop? Did you get foot drop?
I got a little bit of a foot drop.
Yeah.
And then came home and pretty much got on the table almost immediately.
Yeah. Talk to me, talk to us about that experience. We typically operate on people and now you're the patient.
Yeah.
What's
so
that experience like?
Probably the most eye-opening experience of my career, to be honest.
Yep.
I wish I could have not had to go through spine surgery to have the experience, if you know what I mean.
Nice little ganglion would have been good.
Yeah, that's right. But it really opened my eyes to what it's like to be a patient with a problem, and then, you know, the uncertainty around the surgery and the uncertainty around where you're going. And, you know, there's definitely a few things that we've taken away from it.
Yeah.
And as you know, we're about to try and roll out a basically system overhaul with this guided patient system.
Yep.
To try and fix a bunch of the things that I saw as a patient.
Yep.
And so, you know, like I've had a good clinical outcome.
Yeah.
But I think along that journey, there's things that we can do to optimize it. And I think if I hadn't gone through that, I would have never known.
Yeah. What areas in particular?
I think it's just having more touch points along the journey.
Okay.
And it definitely, what I noticed was it doesn't need to be the surgeon. I think what we've always done pretty well is build a team who is basically like all our whole team does all the time really is shoulder surgery.
Yeah. And
so it's a group of people, not just me, who are just dealing with shoulders pretty much all day, every day. So it builds a lot of institutional expertise. But I think leveraging that in a way that improves the patient experience is something we're going to try and do more and more of now.
Yeah.
And that's why I've just started advertising for the clinical nurse.
Yes. Yeah, concierge type role.
Yeah.
It's pretty exciting.
To try and kind of fill in the gaps and fill in some of those touch points.
Yeah.
What do you think of the nurse concierge idea?
Yeah, I think it's a great idea. I mean, I myself have had a few orthopedic related surgeries. Yeah, you're definitely right. If you're not someone that is used to, which is a large population of our patients that's not used to the hospital system and you know what to expect, it would be great to have that person that is a point of call for being the patient, as well as sort of just talking you through that journey. I think one of the hardest things that is involved in any healthcare role is managing your expectations and the patients and then meeting at a level. It's quite hard to, you know, some people might expect to have surgery and then not be in pain whatsoever. But if you're sort of educated on that process, which would be that nurse concierge role, and even just having that reassurance of, hey, I'm experiencing this after my operation, is this normal?
100%. That's the whole thing.
One.
Yeah. And the fact that recovery isn't linear.
Yeah.
And so like I must have said that 2,000 times a month.
Yeah.
Over my career.
Yeah.
But until you actually go through the fact that, some days you're good and some days you're bad and some days you're good and some days you're bad, you don't really, the words don't mean the same thing as the experience, I would say.
Yeah, it's funny. I, even doing a few sort of post-operative reviews with patients, if you see a patient who has an operation which typically is quite uncomfortable, for example, a knee replacement, and they come in at the 2-week and the 8-week mark and they're like, I'm great, this is the best thing, I haven't had any pain. I will literally say to them, don't tell anyone.
Yeah.
Because if you tell people, they expect the exact same response.
Yep.
Which that part is really hard to manage as a clinician.
100%.
Their expectations.
And I think that's the reason that we make such a big emphasis of talking to patients about how bad it's going to be.
Yeah. Yeah. You're going to hate us.
Yeah.
This decision.
Yeah. Are you sure you want to do this? because then you do get the, like, you know, you get a percentage of people who come back and go, this has been an absolute breeze.
Yeah.
It's like, great, but you need to prepare everyone for the fact that it's not going to be.
Yeah.
But like, because you obviously had your knee done.
Yeah.
Until you've experienced that non-linear recovery, it's just like, it's just words. And then you experience, you're like, oh, it's actually, some days are terrible and some days are good.
Yeah.
And it's unpredictable.
It is. And you can't, one thing that I sort of have to remind myself is I can't talk to a patient who is going to have the same operation that I've had. And I was fortunate that I had a pretty easy recovery. I had knee surgery and I think I was back at work 3 days later. I'm not going to say that to a patient because their expectation may be, or their experience may be completely different.
Totally different.
And that might not have been my choice.
Totally.
So,
yeah.
Sort of.
Well, mate, not everyone's as tough as you.
No, that's not the case. That's not the case. There's lists that need to be done.
yeah, that's right.
And Panadol and Nurofen does work.
Yeah.
So
the other thing that's been interesting is like the integration of allied health around a busy life. Like the physio thing, when I do the physio, I feel heaps better than when I don't.
Yeah.
But it's finding time to do the physio.
100%.
And like, you think about the number of tradies that we treat that are like, well, I got to get back on the tools. I don't have the time to do physio and blah, 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 blah. It gives me new kind of compassion for the fact that fitting that stuff in is difficult.
Yeah.
And I think over the next 5 years or so, we'll see a lot more, and hopefully with the guided patient system that we're rolling out, I'm hoping that some digital solutions for people like that, that's going to be better than not doing anything at all.
Yes.
And so integrating some of those elements around the patient journey, I think could be a big win as well.
Yeah.
But watch that space.
Yeah. I think the physiotherapy stuff, particularly the first thing that I think about with physio is cuffs.
Yeah.
How like integral they are to the recovery.
Yep.
There's only so much that you can do. I mean, you know, you can fix a rotator cuff, you can educate them, but the point of contact is limited post-surgery.
Yep.
The physio really adopts that role of I'm going to be the one that gets you back, and having the right exercises prescribed and doing them is like...
Oh, it's the difference between a good outcome and a terrible outcome.
100%.
Yeah.
Yeah. So those guys are like worth their weight in gold.
Yeah, agreed.
To the recovery.
And cuffs are a really good example because we are trying to create inflammation.
Yeah.
And inflammation gives you pain. It's the same with nerve surgery. It's like you fix something, more blood flow comes to the area. That blood flow brings inflammatory cells, which is part of the healing process.
Yes.
But you know what hurts?
Yeah.
Inflammation.
Yeah, that's right. I'm sure you're meant to be.
Yeah.
It's
this
good sign.
Yeah, it's this real hard kind of, like we're kind of happy it's a bit sore because of the inflammation, but if you're sore, you can't move. And then, well, how do we get movement around a joint that's sore to try and hopefully desensitize those nerves, get blood flow, things like that.
Yeah.
And so it's a real tricky balance.
Yeah. For the, we've had a few physiotherapists that have contacted you and said that they enjoy listening and stuff, which is great. For those guys, what are some red flags that you think that they should be aware of when we've just spoken about pain is good to a certain degree? When is pain bad? What's the...
That's a really good question. So the big one for us post-operatively is frozen shoulder.
Yeah.
Because if you can intervene with a frozen shoulder early, they tend to do a lot better.
Yes.
And so what we try and get out there in the community is that pain's okay, but pain that continues to go up or lasts more than kind of 24 hours, particularly when it is associated with clinical decline.
Yep.
So if your pain's going up and your movement's going down, they're probably getting a frozen shoulder.
Yes.
And what we then do typically is MRI early to make sure there's no structural problem, so the cuff hasn't ruptured or something like that. And then if the cuff's healed, then you can start looking at interventions like steroid injections into the joint to try and free the joint up, which is a really effective treatment in early frozen shoulder.
Yep.
Particularly post-operatively, as you've seen. So yeah, I think that kind of crescendo pain with decreasing range of motion would be the big one for early review for me.
Yep.
And then there's all those other kind of red flags for pain that everyone talks about, but specific to what we do, that's the one.
Yeah. Okay. That's a good point.
Yep. And I've just started going back to the gym.
Yeah. Little Frank, who apparently is not so little.
Little Frank is the biggest human I've ever seen.
Yeah.
He's a giant.
Yeah. How's your rehab? How's the experience going?
Mate, it's been really good.
Yep.
So obviously we used to do CrossFit together all the time and I love it.
Yeah.
But like just physically, I can't do it at the moment.
Yeah.
So over the last sort of 3 weeks, started to get back into some physical training, and Frank's a bit of a wizard actually.
Right. Okay.
Like he really knows what's
What
going on.
is his background?
It's strength and conditioning, and I'm going to
Yep.
butcher it because I don't actually know what his titles are. But
Yep.
some people just get the way the body moves, and
That is so true. Yeah.
it's the same with like physiotherapists and massage therapists and stuff.
Yeah.
Some people are just fixers,
Yeah.
and it's probably the same with us to a degree.
True.
And he's one of those guys who just gets it.
Yeah.
He like immediately was like, oh yeah, these are all the places you have problems.
Yeah. How good is that? How humbling is that?
Oh.
You know, you can do all these movements, and then someone says like, hold this hip extension in this position, and you're like, I can't do that.
I actually just can't do it
because you're super weak.
Yeah.
You're like,
but
oh,
also
right.
my brain just can't tell whatever muscles they are to work. It's like, what is going on?
What do you mean? It's pecs and bicep. That's all we know.
Totally. So it's good to be moving again for sure.
Yeah. And noticing significant changes, or is it still pretty? Yeah. Okay.
Yeah. Interestingly, not doing that much stretching, doing a lot of muscle activation work, and my mobility is getting better.
Okay.
Which isn't something I necessarily, with conventional teaching, typically stretch for mobility. But I think there's enough data out there now, and certainly it's what I've seen working with Frank is, putting yourself in positions you're weak and strengthening those muscles improves your range of motion as well.
Yep.
So shout out little Frank.
Yeah.
He's been great.
I have to see this guy.
Yeah, mate, you got to come meet him. He's enormous. He's enormous.
He trains quite a few of the guys, I hear.
Yeah, so I actually got in touch with Frank through Dave Rodder, business partner.
Yeah,
and
he's looking pretty fit at the moment. So
Dave's looking, he's looking dangerous.
Yeah, he's going to be on the next podcast, hopefully.
Yeah,
David.
Hopefully he's ready.
Yeah. Speaking of yourself and David, you guys have been pretty flat noise.
Well, mate, I think we all have.
Yeah.
I don't think it's been David.
You guys in particular I feel like are burning.
Oh, mate, it's been a busy time.
Yeah.
Everyone's moving, including you.
Yes.
But yeah, we've just in the process of moving the rooms.
Yeah.
So obviously the hospital fit out at Maroochy Private's basically done.
Yeah.
First cases are in like 4 or 5 days.
Yeah.
We don't start there until like the first or second week of July. But yeah, the first cases will be this week.
Yes.
So that's one part. But the other part with that is we've moved our rooms.
Yeah. I actually, not too long ago, I finished up a list with Luke and I went downstairs to do some admin. It's the first time I've ever gone down to Skog and there's no one there.
Yeah, it's ghost town.
And it was great. Yeah. So much work done.
And so it's been really like good and like a little bit sad to move out of those rooms. Like we've been there forever.
Yeah,
like Dave in particular has been there forever.
Foundation.
Yeah. And on to bigger and better things.
Yeah.
But the transition process, like I don't know if any of the listeners have ever kind of had to run a business while also moving the business to a different location.
Yeah. Very challenging.
Oh.
Yeah.
It's a total nightmare.
Yeah. The rooms look pretty nice, I hear.
The rooms are good.
Yeah.
Yeah.
There's a massive red phone somewhere.
Yeah. So to tell that story, I was doing my first clinic there and basically there was a handover date and we kind of like, we see a lot of patients each week.
Yeah.
And so there was a handover date that we needed to commit to. And then after that, we needed to move the clinics over because otherwise you're generating 500 phone calls for our, practice managers and admin girls who are already so under the pump, they have no time. So we moved in and on that day they go, the air conditioning is not going to be connected.
Yeah.
I was like, okay.
Good thing it's winter.
Yeah, good thing it's winter.
Yeah.
And so it wasn't too bad. They put in some industrial air conditioners and so it sounded like there was an airplane taking off inside the room.
Fantastic.
But the sign wasn't up yet at the front door. So like behind reception, there's we have a Sunshine Coast Orthopaedic Group sign.
Yeah.
And so I came out about halfway through that day and they were drilling a big hole in the wall. Like it was like a 60 mil hole. Like it's quite a significant hole.
Yeah.
And I was like, oh, they must be putting the sign up. And then I went back to one other patient came out and they'd put a red fire phone in the middle of the wall behind reception.
And it's not at eye level, is it? It's above.
Like, it is like the center of
this
this giant wall. There is a big red emergency phone.
Yeah.
And I just was like,
there's no way.
who has designed this?
Yeah.
Like, why is that going there?
Yeah.
So apparently it's some kind of like there's some fire code.
Sure.
And so you have to have it at reception. But there's about 4 other walls around there that aren't the main wall.
Correct. Yeah, because
So-
it's quite a that wall's like it's a centerpiece, right? It's what everyone's going to be looking at because all the chairs pretty much face it.
Yeah.
And they just see this
There's a big
hot
red wall.
phone.
Yeah. So anyway, it may have to say there we're talking to the fire engineers and we'll work it out from there.
Yeah, just another thing. Just add it.
Exactly right. So
Yeah.
you're already moving this business and now you've got to have like 40 phone calls about a fire phone.
About a phone.
Yeah. Like, what are we doing? But it's super exciting.
Yeah.
Like,
Yeah.
you know.
It seems to be, I mean, the sort of, I guess, I don't know what you would call them. David's tour guides, I might call them. We've had a few businesses come through.
Oh, yeah.
Dave's showing people around and it's, they're getting more and more elaborate, which is great.
It's so good. I reckon I've been, so like that is essentially, you know, new staff or prospective staff or other people we want to show around. Well, there's this beautiful rooftop tea room there with ocean views and stuff. Like, it's an incredible spot.
Yeah.
So typically we'll start up there, welcome everyone, and then David will take everyone on a tour.
Yes.
So I've been on about 9 tours with David now.
Yes, great.
And the man can give a tour.
He can. I think he's missed his calling.
Yeah, it's incredible.
David's tour guides.
It is incredible. And he kind of like, because I've seen so many of them, he's kind of fleshed it out over time.
He's picked out the just sort of jokes that land and ones that don't.
And the key kind of spots too. Like you stop at it's really good.
Yeah.
No, but it's been really fun. And I think in 3 or, you know, hopefully 3 months, but probably 6 months, we'll feel really settled. And, also just with that, like back to that kind of nurse concierge guided patient system idea. It feels like that space is much more built for that kind of journey.
Yes.
Like with the booking rooms and the flow of the clinic and things like that.
Yeah, it doesn't take many, if you're in sort of a smaller room, it doesn't take many patients to A, be waiting and then B, a couple bookings and it gets pretty chaotic pretty quick. But having that whole structured flow where it's never really going to isolate one place to having a large group of people.
Yep.
You know, being like, where am I going? Who's sorting this out? It's all going to be sort of have its own little pigeonhole per se.
Yeah, it feels really, it feels like it'll be really, really good.
Yep.
Once it's all done. And then, you know, on top of that, there's the physio part of it. So Fortius Allied Health, which is going to be integrated into the hospital.
Yes.
To do both the inpatient and the outpatient rehab, that like real integrated patient experience.
Yeah.
But then that's a whole nother fit out. That creates a whole nother set of problems that we've got to manage.
Massively.
So it's been real fun. But yeah, there's a few moving parts at the moment.
Nice when it's done.
Yeah, I can't wait to just sit in there at one point and be kind of happy that everything's done.
Yeah,
and
just a big sigh.
Yeah.
And you just know that.
Well, and hopefully when Dave comes on the 26th, we'll be we'll be happy and we can kind of go, it's ready now.
It's going. Yeah, that will be good. Speaking of this, sort of a little bit more off topic, I don't think the last podcast you'd gone away yet. Had you done Singapore?
Yeah. No, I hadn't.
Yeah, you hadn't. No. Yeah. So talking about that experience.
Yeah, so one of the things that actually like the back thing kind of opened up was a bit more of a focus on the kind of surgeon peer-to-peer education stuff.
Yeah.
And so I kind of started reaching out to a few companies because I thought, you know, there was a period of time there where I wasn't operating very much.
Yeah.
I was like, this would be a good time to kind of go and see some really cool advanced skills and try and build the portfolio out and also do some, you know, I've been lucky enough to be invited to do teaching for other surgeons now.
Yep.
Which has been really a humbling journey.
Yeah. What is that? What is it like teaching a group of surgeons when they, I mean, you know, experiences and everything, but, you know, these guys have a lot more miles on their tires than you do.
Oh, it's crazy.
Must be quite
intimidating.
Very intimidating.
It's like imposter syndrome on absolute steroids.
Yeah.
So, but like there are some things now that we do have like a lot of experience in.
Yes.
Like the robotic shoulder stuff. Like we've got a very large data set on that now.
Yep. New study.
Yeah. And we're starting to publish a lot of that data that we've collected over the last 12 months.
Yep.
Which is exciting. But that kind of helps settle me a little bit.
Yeah.
But then you got to give other talks that it's like, well, you know.
Yeah. I think there's a lot of you know, a lot of clinicians across all facets of healthcare, whether it be doctors, surgeons, nurses, anyone, the imposter syndrome thing is really hard to avoid when you are sort of let out of the gate, out of uni, or you finish your postgrad, or you're stepping up into a new role.
Yeah.
I think there's a lot of people that feel it.
Oh, definitely.
And it's managing it is,
interestingly, so like I started doing that teaching stuff probably 2 or 3 years ago.
yep.
And at that time, it was really bad. Like I
Yep.
felt really like I had quite bad imposter syndrome.
Mm.
And so I would ask a lot of the senior guys, "Oh, did you ever get this? How do you manage it?" Blah
Yeah.
blah 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 blah. And what kind of put me at ease a little bit was they all universally said, "I still get that."
Yeah. Yeah.
It wasn't like
if someone says I don't get it, you're not working.
yeah,
Like, I don't know.
yeah.
Yeah.
So yeah, like it was nice to know that it doesn't go away, and
Yep.
then you just work out how you manage it.
Yeah. I think it's also a good sign that you're continuing to push your own boundaries.
Yeah.
So every time you reintroduce a little bit more, let's say imposter syndrome, it's because you're doing something outside your comfort zone.
Yeah.
And that sort of being stagnant is, you know, what are you doing? You know, are you getting the tap on the shoulder soon? Like you need to always progress and always advance because there's so much stuff. It's very easy, I think, to get lost and get left behind if you don't put yourself out there to do that sort of stuff that you're doing.
Totally. And I think over the last 6 months, I've gotten a lot better at the public speaking thing.
Yep.
Which has been like a fun journey in itself. And it's less anxiety provoking now than it was, 2, 3, 4, 5, 6 years ago.
Yeah.
We do get prepared for it a little bit through the
so they do training essentially.
Yeah. Which so I did one with Striker like 2 or 3 years ago.
Yep.
The whole like training the trainer idea. And then I've recently done another one with Smith and Nephew. And they were probably the 2 best courses I've done.
Yep.
Just
similar
in terms
things?
Yeah, similar things at a different lens.
Okay.
So the Striker one was quite formal, and then the Smith and Nephew one was less formal, but equally, they were both equally useful. But having done both was really, really good because they kind of give you different skills.
Yep.
But it's just the whole idea of like, what is your message and how do you convey it? And then if you do get like a hostile in the audience,
which is
happens.
It does. You surgeons are ruthless sometimes. Someone's talking about something, and someone will just say, "Nah, I'm gonna try to light this guy up."
Yeah,
it's astonishing.
They will definitely. You will definitely have a hostile in the crowd occasionally. And so it's been like they try and give you some skills around that. But ever since I went to those courses, I've been watching how those guys who are on the circuit like all the time, like, like George Athwal, Ian Lowe, those guys.
Yeah.
How do they manage those questions? I've been lucky enough to be at a few conferences with them.
Yeah.
And God, they're good at it.
Yeah, right. Just manage it, hash it out.
Oh, it's always just, it's never aggression. It's always just this really humble, like, that's a really interesting perspective. I haven't really thought about it like that. What I think is blah.
Yeah.
And then normally those guys have got like a boatload of their own sort of data and evidence they can draw on.
Yeah, right. Yeah.
But just the techniques around diffusing someone has been real interesting to learn.
Yeah, okay. That is cool. That is very cool. So what were we actually learning? What'd you learn?
So went to Singapore and did a bunch of stuff with Smith and Nephew around like instability surgery and bone blocks.
Yep.
So different ways to augment. One of the problems with instability is, the more times you dislocate, the less structure is left in the shoulder.
Yeah.
So you tend to wear the bone away.
Yeah.
And one of the tricky things to manage is on the glenoid side. So it's like a golf ball sitting on a golf tee. The golf tee side, bone loss there's a couple of ways to manage it. One is a lattiger where you kind of take off typically open surgery. You take off the coracoid process and bolt it onto the front of the glenoid.
Yeah, like a stop.
Yeah. Which is a good operation, but there's nothing after that.
Yeah.
So if that doesn't work, it's a disaster.
Yeah, that's your salvage operation almost, isn't it?
It's kind of the
your
last
lower trap.
More or less, it's the last stop.
Yeah.
And so what there's more and more data around is using allograft like distal tibia. And what allograft is, it's like donated bone. And the good thing about distal tibia is it has cartilage on it.
Yep.
And so Ian Lowe's got a really big series out of Canada, and he was at the Singapore course. And so we learned a bunch of stuff from him about techniques around that to augment glenoid bone loss. So that was really good. So that was one of the big clinical takeaways. And then everything else was just kind of reinforcing what we've already been doing. So, we do lots of remplissage. That seems to be becoming more and more a talking point for reducing dislocation rate. More and more soft tissue, less bone work, which again seems to be becoming more consistent at the meetings we're going to. So that was really good. And then the following weekend went down to Sydney and spoke at the Masters Symposium for Arthroplasty of the Shoulder with Stryker. Which was awesome. There was it's probably the most nervous I've ever been.
There's some big hitters there.
Oh,
yeah,
like big global hitters.
Yeah,
like lots of big Australian hitters.
Yeah,
but JD Worthall and George Athwal were both there, who were like big international hitters.
Yeah,
and having to get up and talk about shoulder surgery in front of those guys.
Yeah, yeah, you can see how you could get in your own head pretty quick. Like, what am I doing?
What is going on? But they were both great and had some really interesting conversations. And Trav Falconer and Eugene Eck kind of chaired it, which was really good because I've had stuff to do with them through the Mako process.
Yeah.
So they were both really awesome to lean on. Same as Levi Moore. So it was really, really good.
Yeah.
Yeah.
Yeah, I think that's a good point. You mentioned before you learned some new stuff and then it reinforced some stuff. I think, you get invited to go to these conferences and, things like that. And there was one down in Sydney that I recently went to where you might not learn groundbreaking things, like, oh, wow, that's going to change my practice. But if you go there open-minded and everything is reinforced, it's still a good outcome. It's still worth going.
100%.
And I think people can get sort of lost in the moment. They go to these things and, they're telling you how the wheel works. You know how the wheel works. But it's reinforcing to you. You're doing what everyone else is doing.
Yep.
Which is that's not boring. That means that you guys are all doing the right thing.
Yep.
And if anyone's talking about doing something new, then you're all there to sort of weigh in on it.
Totally.
So I think that's pretty important.
And I think the other thing you said at the start is really important. You got to go to those things with an open mind.
Yeah.
And understand that things change over time. And not to say you want to grab everything that changes, because not all ideas are good ideas.
Definitely.
But you do need to know what the current kind of things that are gaining traction are.
Yeah.
Because, particularly one of the reasons I did shoulder was there are so many unanswered questions.
Yeah.
And so we're at a time at the moment where things are really changing rapidly. So if you go into these things and you're not listening to guys who are doing lots of different stuff, you got to wonder, like,
why you're there.
Yeah. And also, not everyone knows everything. And the guys who are really, really good and really smart tend to acknowledge that they don't necessarily have all the answers all the time. And it's the constant kind of refreshing and questioning why you do certain things that you do that I think makes guys like George and JD.
Yeah. I mean, those meetings, right? They're not necessarily you're sitting down in a chair listening to these guys. It is a collaboration. You guys all essentially do the same thing.
Yep.
But you're just there to pick ideas and has this been tried? Things like that.
So. Well, I got up and spoke about one of the talks I gave was on the Mako case experience, so robotic shoulder replacement case experience.
Yeah.
And essentially that's getting up and showing everyone this is how we do a robotic shoulder.
Yeah.
In front of a room of guys who are really good at surgery.
Yeah.
And so
this is the humerus.
Yeah, that's right. Yeah. So it was from that point of view, it was a really good experience and like a nice test bed, and showing our data and our results was it was fun.
Yeah.
Yeah. Really fun.
Good experience.
You're moving as well, mate.
Yes, yeah. So I guess with all the everything going on at work and stuff, relocating and things like that, which has been it's been what it's like for everyone.
Yeah.
Stressful. It's not only just stressful on me. I've got someone at home that's been great with it.
Yeah.
It's probably taken a large burden of it. But yeah, it's interesting. You go to work and then you come home from work and then you're thinking about 1,000 different things and then you're doing the exact thing over and over and over. But that's just a sort of a life thing, I guess. It's all
I hate moving house.
It's the worst. It's the worst. And all you want to do is just shut the door and chuck everything out.
Yeah.
You can't do that.
Totally.
Then you need cash to buy all the stuff.
Yeah. But it's like you're so happy in your own space and then you've got to totally uproot everything.
Yeah.
And then
you figure out new stuff, what you're doing. I mean, it's going to be the same at Maroochy, all right. We're going to, this is what I normally do, but I don't know where that is.
Yeah.
And you got to ask everyone.
Yeah.
So, which is that's life, I guess.
100%.
So
The through training, we obviously have to move all around the state all the time.
yeah.
And so like every year,
I could not actually fathom what that would be like.
it's
I just
terrible.
think that would be the worst. That must be one of the worst parts of training.
Oh, it is the worst part of training. It's the
Yeah.
I went from Townsville to Brisbane, back to Townsville, back to Brisbane,
Yeah.
moved in Brisbane twice.
Yeah.
And some guys get sent all around the state.
Yeah.
And we had Sunny Coast as well. So it was like quite a lot of moving around.
Yeah.
Which is just terrible. The only thing that makes it remotely palatable is Queensland Health does an amazing job, actually.
Yeah.
If you're moving to or from a regional centre, they did at that time at least, help, like they organise removalists, help organise removalists for you. They pay for it.
Yeah.
You can get your stuff packed by the removalist. So from that point of view, it's amazing.
That's a game changer.
Like it's amazing.
Yeah.
But you're still literally going, okay, well, this year I live in Townsville, and next year I live in Brisbane, and the year after I live on the coast, and then I'm back in Brisbane.
And there is a
then
level
I'm
of
New South Wales,
for those who aren't aware, you guys, you go through orthopedics, right? And let's say it's a 5-8 year deal. It's different for everyone depending how you go. But you're not given like, okay, this is your 5-year plan. You're going to go here.
Oh,
here.
no.
It's like, okay, you guys put in your preferences and we'll see how you go.
Yeah, I think it's like, I feel like it was like August or September of the year, of like this year.
Yeah.
You'd find out where you were living in January.
Yeah. It must be hard because you want to settle somewhere and you get to meet people and then it's temporary for a long time.
Yeah.
And
which, to be honest, is one of the really not like, so Townsville in particular was super fun.
Yeah.
Because everyone is only there for like a window.
Yeah.
And so everyone's trying to meet new people.
It's like being away for a ski season. Everyone's just like, let's work, but let's have fun.
Yeah, it's the real dorky version of being away for a ski season.
Work related. But yeah. No, mate, what is going to be exciting about Maroochy is I'm finally going to basically have the 3 people that I work with in the same centre. That's going to be great.
We could talk about that.
Yeah. Yeah. Yeah, of course.
Yeah, I can't wait. So very excited to have Luke around more. He's great. One of the all-time great dudes.
Yeah.
Really good cutter.
Yeah.
Massive value add to the hospital.
Yeah. Yeah. Took a bit to get him across. But,
took a bit to get him across. Yeah.
Hard man to track down.
Yeah, you can't pin that man down.
No.
But very, very excited to have him over there.
Yeah. I think it also will bring a slightly different view to the place, which will be really nice.
But also he's just a value add to the really important thing about starting something like that is the culture.
Yep.
Like if the culture's terrible on day one, it's almost impossible. Like it's not impossible.
Can't change that.
It's really hard to change.
Yeah.
And what Luke is great for is culture.
Yeah.
He's amazing with the nursing staff. He's a really good guy.
Yeah.
Just one of those really sort of like efficacious personalities. Like he gets stuff done.
Yeah.
But he gets it done in a way that everyone wants to kind of get involved.
They want to jump in. Yeah, exactly. Yeah.
Which is, mate, hard to find.
Yeah, for sure. Yeah. Yeah. God, he's
particularly amongst surgeons.
Yeah. He's prepping, draping, he's doing everything, man. So wow.
Yeah.
I'll chill.
Yeah.
I'll sit back.
Totally.
Nah. So yeah, that's good.
I was talking on the you know how I went down to Brisbane this week to talk on that panel for work cover?
Yes.
Not work cover, it was the self-insured sort of group, ASIEQ.
Yeah.
And we're sitting on a panel and it was me, Jörg Rau, who's a surgeon in Brisbane, Travis from hands-on hand therapy in Brisbane.
Yep.
Then an ED physician we work with.
Right.
And Travis, we're all sitting up there talking and blah, 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 blah. And Travis just goes, but nobody wants to call a surgeon because you're all grumpy.
Yeah.
Not quite that.
I think that's changing. I think they really are.
Yeah, well, that's what me and Jörg were trying to say.
Yeah,
it's like, mate, give us a break.
Yeah, we're these new age guys.
Yeah.
We're friendly.
Yeah, we're friendly people. But that's Luke, right? Luke's
100%.
He's a really good dude.
Very approachable, no matter what the question is, which is really good.
But yeah, it'll probably simplify your life a lot.
Yeah, big time. Yeah, all under the same building. Which I mean, we still got lists at different hospitals, but for the majority of it, it should be really, really nice actually. But yeah.
Well, we'll get David on next time, hopefully, and talk about the rollout.
Yeah, that's going to be very exciting. I think he's got a bit to say. So I'm pretty excited for the big fella.
I hope he gets controversial. You know?
Very good.
Right, thanks, bruv.
Thank you.